This segment is on burns. And the first thing I want us to talk about as we start to talk about burns is a little bit about assessing burns. And I want to start out by talking about the rule of nines. And the first thing I want to ask you is how many nines go into 100? All right, think carefully about your answer. There are 11 areas of 9%. So the body is divided into 11 areas of 9%. 11 times 9 is 99. And that extra 1% is the perineum. Now, the rule of nines applies to adults only. It is not appropriate for children because children have their bodies are in different proportions. So the rule of nines is appropriate for adults only. And it gives us a general idea, a quick assessment. It's just a way to do a quick assessment of what percent of their body area is burned. So as we talk about the rule of nines, the head and neck is 1 9. So the head and neck is 1 9. The front of the head is 4.5%. The back of the head is 4.5%. Together that totals 9%. So the head and neck is 1 9 or 9%. Each arm is 9%. So the front of the arm is 9% and the back of the arm is 9%. Or you could say the lower half of the arm was 9%, the upper half of the arm is 9%. So that each arm is 9%. The anterior trunk is 2 9s or 18%. And the posterior trunk is also 2 9s, or 18%. And each leg, being longer and fatter than the arms, is 2 9s, so 18%, 9% front, 9% back. And the last area is 1% in the perineum. So if we think about that, we think the head and neck is 1. Each arm is 1 9. Anterior trunk is 2 9s. Posterior trunk is 2 9s. And each leg is 2 9s. So it goes 1, 2, 3, 4, 5, 6, 7, and then down to the legs, 8, 9, 10, 11. So there are 11 areas of 9%. And as we said, this applies only to adults. Let's do a question about that. A patient is admitted who has partial and full thickness burns on his chest and abdomen and on his right forearm. The nurse knows that he has approximately what percent of his body burned? So 13%, 18%, 22%, or 27%. And the best answer to this is answer number 3, 22%. So the anterior trunk was 2 9s, that was 18%, and half of the arm was 4.5, which would be 22.5%. The closest answer on that slide is 22%. Now we said that the rule of nines applies to adults only. And I want to show you a picture of children. I don't think you have to memorize the children, but if you take a look at the difference between the proportions with adults and children, if we said the head and neck of the adult was 9%, if you have a newborn, half of the head is 9.5%. So the whole newborn, we've got 19 to 20% with the neck involved. And the head, because the baby, the biggest part is the head. Now, as the babies get older, the head is smaller proportions. The legs and arms get longer in relationship to the trunk as the babies get older. I don't think you need to memorize those kinds of numbers for infants and children. We often use something called the Lund-Broder scale, where we look at the age and height and weight of the child and look at the percent of body burned that way. But I don't think you have to memorize those, but I would memorize the rule of nines. Now we want to assess in terms of the burn depth. And I like this little diagram here because it shows us the skin pretty well. And you can see with your superficial layers, you can see the epidermis. You can see then the dermis and the subcutaneous tissue with that. You can also notice the nerves. So you notice the nerves. And you might notice the hair follicles, where the hair follicles come out as well. So we'll look and think about the effects of various types of burns on those functions. And we're going to talk about the terminology for burn depth, and that has changed a little bit. When the burn involves simply the epidermis, or that top layer of skin, we used to call this a first-degree burn. We now use the term superficial partial thickness. So it's on the top layer, superficial partial thickness. This is like a bad sunburn. So it's like a bad sunburn. Another picture of a sunburn here. You can see where this patient had a really bad sunburn in the area then that was covered, of course, when they got that sunburn. When the burn involves the dermis, the next layer down, this is referred to today as a partial thickness burn. We used to call it a second-degree burn, but today we would use the term partial thickness. This is usually characterized by blisters. And in this picture, you can see blisters. You can see it here, the swelling and the blisters. You can also see this is a hand that's been wrapped between the fingers, which we usually do when we wrap that kind of burn. But a second-degree burn or a partial thickness, deep partial thickness burn usually has blisters. Now, what we used to call a third-degree burn involves the subcutaneous layer, and this is usually now referred to as a full-thickness burn. Notice by the time you get down into the subcutaneous layer that the nerve cells have been damaged as well. Now, a third-degree burn or a full-thickness burn is pretty ugly. It's often characterized by black looking areas, or sometimes kind of ashy white areas. So there's often a lot of charring blackness look, and sometimes powdery white. So we're going to look at a picture of a third-degree burn, and I know it's a little ugly picture, but you can see on this, you can see the black charred area, and you could also see a little bit of white powdery area as well. This is another view of a third-degree burn. I'm going to move off from those fairly quickly because they are rather uncomfortable pictures to look at. Now, sometimes burns will be so deep that they'll go down and involve the muscle and even down to the bone. So you can actually, it burns away the entire muscle. We used to sometimes talk about these as being fourth-degree burns. They would be described as being a very, very deep, full-thickness burn. And I have a picture of a fourth-degree burn or a really deep, full-thickness burn. And in this picture, you can actually see the bone of the fingers. So let's kind of summarize a little bit about burns. This picture shows us the first-degree burn, or the superficial partial thickness, which is more like your sunburn, your red area. The second-degree burn, or the partial thickness burn, the deeper partial thickness burn that's got blisters, and your third-degree burn, or your full-thickness burn with the charred areas, or sometimes even the powdery areas. So this also summarizes what we have just said, differences in the color and the surface of that. And this slide, you can look at it, but it simply summarizes what we have just been talking about. Now, which burn hurts the most? A first or a second-degree burn? Notice that a third-degree burn has no feeling in it, because those the nerves, the pain that conduct pain, tell us have been damaged, have been burned. So that insensate means that there is no pain in a third-degree burn. However, most third-degree burns have first or second-degree burns adjacent to them. So the patient does usually suffer from pain from the second degree burns that may be near to them. Another type of burn I want us to think about is an electrical burn. And an electrical burn, electricity has gone through the patient. This is a little bit different than a flame burn. You might get an electrical burn from lightning. You could get an electrical burn from handling or touching a very high tension power line. Children can get electrical burns when they stick metal objects into light sockets. So there's a number of things that can cause electrical burns. Electrical burns have entrance and exit wounds. So there's an entrance wound where the electricity entered, and usually an exit wound where it leaves the body. Now, this picture shows us an entrance wound for this electrical burn. This child had been chewing on a cord, and we can see an entrance wound. Now, the problem with electrical burns is that when that electricity goes through the body, while it may not be so dramatically visible, the damage is on the inside. What happens? Now, one of the biggie things is when you put an electric shock through the body, it can cause dysrhythmias. So dysrhythmias are a major, major concern. They can be immediate or they can be delayed up to 24 to 48 hours. So with an electrical burn, one of your highest priorities is an ECG to see if they have any dysrhythmias, many of which could be potentially fatal. And remember to keep on observing that for at least the first 24 to 48 hours. Now, with an electric burn, we see a metabolic acidosis that can develop within minutes because of the severe damage to the muscles inside the body. Another big concern with electrical burns is fractures. And you think, why would you get a fracture with an electrical burn? That electricity causes the muscles to go into such sharp spasm that spasm of the muscles actually physically can break the bones, so that we see fractures, particularly in the long bones and the vertebrae. One would not think about that unless you kind of thought through the physiology of the electric burn. Another real problem with an electrical burn is that this muscle tension, this trauma and damage to the muscle from that electric shock going through can cause what we call myoglobinuria. So the protein from that muscle damage, the protein breakdown, can cause myoglobin to get into the little blood vessels and renal tubules. And I put this picture in here for us so that we can take a look. If you look at this part over here, you can see what it looks like with all this myoglobin that's in the urine. And as the patient gets enough fluid replacement here, you can see the urine clearing up a bit. This back here will block the renal tubules and can cause renal failure. So the patient is going to need fluids, usually something like Ringer's lactate, at a fairly decent rate, 75 to 100 milliliters an hour, to flush the kidneys, and sometimes also an osmotic diuretic to keep that from collecting in the renal tubules and causing kidney failure. Now, if we think about the treatment of burns, we can break this down into several phases. The pre-hospital care of burns. First thing we need to do is stop the burn, remove the patient from the area. We also need to think about airway, so check for patency. If you see soot around the nares or singed nasal hair, this is a good sign that the patient may be at high risk for smoke inhalation. Burns that take place in small enclosed spaces increase the risk of smoke inhalation. Areas where chemicals are burning, whether it's burning drapes or carpets or chemicals in a factory that's on fire, any kind of chemicals in the air can also increase the risk of lung damage. We think in terms of our ABCs, the airway, the breathing, circulation, checking for pulses. You don't want to immerse a large burn in water, and you don't want to pack it in ice because that can reduce the circulation to the area. You could, if the patient was on fire, had a flame burn, you could douse them down with water, but you're not going to submerge it or immerse it in large amounts of water. And if possible, keep the patient wrapped in something that is dry and clean. So this is pre-hospital care. This is before they get to the hospital. Another way to think about this is to think about stop the burning process. So that means stop, drop, and roll. And we teach children from nursery school on up. When you have a burn, the big tendency is, if your clothes are on fire, to run. And that, of course, fans the flame, and that's the worst thing you can do. So stop, drop, and roll to smother the flames and stop the burning process. Put a coat over the patient, a blanket over the patient. Flush if it's a chemical burn. So if it was somebody in chemistry lab or they poured chemicals from work on their system, flush is the best thing to do. If it's an electrical burn, you need to turn off the power before you touch the patient. Because if the patient is still connected to the power and you touch the patient, then you also are going to be burned and have an electrical burn. So turn off the power. We then need to think about airway and oxygen, and we mentioned that before, but I can't say this too much. Airway and oxygen. I'm going to show you a picture of a lung scan of someone who's had a burn. And if you take a look at that, those dark areas are smoke inhalation. And that's pretty serious when you see those kinds of things. And that can happen with burn, particularly, as we said, those that are in enclosed spaces. Now, in addition, once the patient is at the hospital, then we look at some more phases of burn management, the emergent or the resuscitative phase, then the acute and the rehabilitative phase. Now, in this emergent or resuscitative phase, it's from the onset of the burn through the first 24 or 48 hours. It begins with the fluid loss and the edema that develops and ends with the fluid mobilization and diuretic phase. During this phase, when the fluid is moving out of the bloodstream into the tissues, the biggest problem for the patient is hypovolemic shock. So let's see what happens with that fluid shift. In these first 24 to 48 hours, the fluid moves. It moves from plasma to interstitial. And I'm going to put up a picture that really gives us a sense of how much fluid is moving. If you take a look at this picture, you could hardly even recognize that as a person there. There's so much facial edema. Sometimes you will have patients who have so much edema in this phase that when their relatives come into the burn unit to visit them, they'll walk right by them and not even know that this is their loved one. They're that unrecognizable. So we have that fluid shift from plasma to interstitial. During this time, we see acidosis. The hematocrit rises, and then the serum potassium rises as well. When you have a lot of cellular damage, tissue damage to your cells, the serum potassium leaves the cell, or the potassium leaves the cells and goes into the bloodstream. So you see a rise in serum potassium. During this shock phase, as it's sometimes called, one of the most important nursing things is to monitor urine output and then monitor the vital signs. Urine output will be hourly, so they'll be catheterized and have an indwelling urinary catheter, and we'll be measuring hourly urine output, monitoring vital signs because they are at great risk for shock. We usually give a lot of fluids in the first 8 hours. In a few minutes, we'll look at a couple of different formulas. But one of the things that seems to be in common for fluid replacement formulas is giving half of the first day's fluid requirements in the first 8 hours after the burn episode. This is to help compensate for that huge fluid shift out of the bloodstream into the tissues. Now, somewhere 24, 48 hours after the burn episode, the capillary permeability begins to stabilize and the fluid now begins to move in the other direction, and it goes from interstitial to plasma. As it does so, we see the hematocrit drop and the serum potassium begins to drop. The urine output now begins to go up. The blood pressure should begin to go up as well. The patient is now at risk for pulmonary edema and an increase in central venous pressure and sometimes full-blown pulmonary edema because the fluid is now coming back into the bloodstream. And of course, the fluids are going to be decreased as this stage progresses. So the physician will order a decrease in intravenous fluids. Now, I want us to look at a couple of different formulas. Different burn centers have different formulas for fluid replacement, and I've chosen to give you two. The first one is the Brook formula. And the first 24 hours after the injury, they start with Ringer's lactate. And you'll see the adults at 2 milliliters per kilogram per percent of body burn. Children, there's 30 children that are under 30 kilograms, 3 milliliters per kilogram per percent of burn, plus a maintenance of D5.5 normal saline. And notice that the rate is half of the first day's fluids in the first 8 hours after the burn episode. Now, in the second 24 hours, one would expect to see a colloid added, such as albumin. This raises the osmotic pressure and will start to pull the fluid then back into the bloodstream. So you would expect colloids, such as albumin, to pull the fluid back into the bloodstream. And the percentages are listed here on this slide for you. I doubt that the exam asks you the exact percentages. They might ask you, though, that you would expect an order for colloids in that second 24 hours. I think there have been questions related to that on NCLEX. Now, another formula is the Parkland formula. And the Parkland formula gives 4 milliliters per kilogram percent of burn. So there are a number of different formulas out there. When there are several formulas, the exam doesn't usually ask you about a particular formula. So they ask you about the general concepts that we see. Now, during that phase where you have an awful lot of edema, you may have pressure, and to the point that it's going to cut off circulation. And so sometimes it's necessary when there is enough tightness in the skin area to do something called an escharotomy. And this escharotomy is when they will actually cut open the skin to relieve the pressure. So when the circulation is impaired and there's a decrease in pulses, they may have to do this escharotomy. Now, a couple other thoughts with the acute phase. This begins with the extracellular fluid mobilization. And we said this ends then when the wound is completely covered or the wounds are healed. This phase takes weeks or months. So once those fluid shifts are complete and the fluid is back in the bloodstream where it belongs, then we're into this acute phase. During this phase, the edema disappears and hopefully bowel sounds will return. Usually during the early phases, when the patient has had severe burns, they may have loss of bowel sounds. But during the acute phase, that returns. Now, if we look at fluid replacement during this acute phase, once the fluid is back into the bloodstream where it belongs, the albumin is stopped. The colloids or the albumin is stopped. And they will then need D5 or D5.5 normal saline for children. We have to watch the electrolytes, the serum sodium. Depending on what's going on with the patient, they could develop hyponatremia from evaporative loss out into the air from the wound, Or if they develop the syndrome of inappropriate antidiuretic hormone production, they could develop hypernatremia. We have to monitor potassium phosphate levels as well. When we think in terms of, to kind of summarize the nursing care, fluid replacement, physical therapy is something that will start very early and continue for years in many patients with severe burns. Wound care, as long as they've got wounds, they're going to need wound care. Early excision and grafting. Pain management is a biggie. With pain management, oftentimes they're given small amounts of pain medication frequently rather than large doses at 3 or 4 hour intervals. Any first, second degree burns are going to be extremely painful. Nutritional therapy is a must for patients with burns. The amount of calories and protein that's needed for skin repair is absolutely incredible. And sometimes the patient's nutritional requirements are such that it's going to be necessary for them to have TPN, total parenteral nutrition, because they simply cannot, even if they can eat, they cannot eat enough calories and enough protein to meet the body's needs for healing and skin repair. The room needs to be warm because the skin is one of the big mechanisms of temperature control. And if your skin is not intact, you're just losing heat out into the air. So that's a major consideration in the care of patients with severe burns. I want us to think about some of the substances that might be used in the burn treatment. And I want us to look at silver nitrate. This has been around, it seems like, well, for many years, let's say. A couple of things to keep in mind about silver nitrate. Dressings need to be moist. You need to monitor electrolytes because it can cause electrolyte dilution. So the patient could develop hyponatremia, hypokalemia, hypochloremia. And silver nitrate turns everything it touches black. That's not good or bad, it just is, but it discolors everything. Another antibiotic that is sometimes used is gentamicin. Now remember that when gentamicin is used, gentamicin is very nephrotoxic. So that serum creatinines and BUNs will be done at regular intervals while the patient is on gentamicin. Gentamicin can also cause hearing loss, 8th cranial nerve damage. You might want to keep that in mind. Another substance you often use to treat burns is sulfamylon. This is an ointment that's applied with a sterile gloved hand. It's done usually for open wounds, but the worry about sulfamylon is that it can create metabolic acidosis as it's metabolized. So you might see the sulfamylon as we see in the picture. Silver sulfadiazine has been used also as a cream for burns. Let's do a question. An adult who is severely burned is scheduled for hydrotherapy. Which nursing action is essential before sending the client to hydrotherapy? 1. Be sure the client has eaten. 2. Administer PRN pain medication. 3. Provide reading material. Or 4. Debride the wound. And the correct answer here is number 2. Administer PRN pain medication. Now when the patient goes for hydrotherapy, they're going to physical therapy, and they're going to be put in a large tub or tank. Sometimes this is called tubbing or tanking. So the patient is put into this large tank and in water. The purpose of this is to make that eschar so that it is softened and easier to debride. So when they're in there and they've got the softened eschar, then they're going to remove the eschar or dead tissue. So when patients go for hydrotherapy or tubbing or tanking, they're going to have some debridement. So they're going to pull out the dead tissue. It's very, very painful. This is a time when you want to anticipate the pain and medicate the patient before they leave the unit. Because while the dead tissue doesn't hurt, the live tissue near it does. And so that debridement is a very painful type of experience. Another question for us. Hydrotherapy is ordered daily for 30 minutes for a client who has severe burns. The nurse understands the chief reason hydrotherapy is limited to 30 minutes is to 1. Promote client comfort, 2. Prevent fatigue, 3. Minimize sodium loss, or 4. Prevent boredom in the client. So the reason that hydrotherapy is limited to 30 minutes is to minimize sodium loss. Now think about this for a minute. This patient with open wounds, with burns, is placed in a big tank of water. And when they're in this big tank of water and they've got open wounds, then the electrolytes will move by diffusion out from the patient into the water. And so they are at risk for developing hyponatremia. This is really a diffusion type question, a fluid and electrolyte type question. And if you got that one correct, congratulations. You're thinking the way you should be thinking. I wanted to take a look at some other types of dressings that might be used and just show you some pictures of them. This is something called a silver dressing. This is a more modern type of dressing that will actually sometimes help not only in healing of the wound, but it may also help with some of the skin development. This shows another kind of silver dressing with all those little silver fibers in there. That does help prevent infection. Sometimes patients will get dressings that have a network, almost like a frame for skin to grow on. And that's used in a number of patients as well. I have a picture for you here of a child who is treated with cultured skin. And you can see that the skin has grown on the child's upper body. His legs are still in a pressure garment. That helps with the healing process. Now, as we talk about this rehabilitative phase, we said that begins when the patient's wound is covered and the patient can begin to do some of his own self-care activities. It can be anywhere from a couple weeks to several months. Hopefully, the patient will be able to resume a productive role in society. The functional cosmetic type of reconstructions, sometimes the surgeries that are necessary in severely burned patients actually string on for years. As the skin grows and matures, they often need repeated surgeries to make it functional. Now, in this rehabilitative phase, the burn heals either by primary intention, which is where the edges, where you can pull them together and they will grow together, or by grafting. This is a time when you can see a lot of scars, a lot of contractures. The pressure garments, we saw a picture of that in that child with a cultured splint. Notice it can take several years for healing of the skin to take place. And the longer periods of time are for the more severe burns. New skin is very, very sensitive to sunlight. So patients who have had skin grafts or who have had new skin by primary intention is grown back need to stay out of the sunshine for at least the first year afterwards. It's also very sensitive to trauma, so they have to be very careful of that. I wanted to show you a picture of a problem that can occur as the patient heals. And this shows a contracture of the skin following a burn injury. Now, the next picture shows the use of a pressure garment that may help to prevent those type of contractures. We need to speak a little bit about skin grafts, and when we talk about skin grafts, there are some terms that we might want to think about. Auto means self, so autograft is when the self is the donor, so they take skin from a non-burned area of the body. Isograft refers to an identical twin. That's not very commonly done, obviously, but that's what the term refers to. Homograft or allograft means that the skin comes from the same species. In this case, that would be a cadaver. Hetero means different, so a heterograft or a xenograft comes from a different species. Frequently, pig skin is used. Now, that's going to be temporary. And sometimes human amniotic membrane is also used as a temporary covering. The only one of these grafts that's going to be permanent is your autograft or possibly your isograft if that was done, but we said that's not very common. The others are all temporary to prevent heat loss, electrolyte loss, fluid loss, until such time as the patient can have an autograft. Now with autografting, you note that the skin is removed from a part of the body using something called a dermatome. So they remove the skin from one part of the body. They may put holes in it to make it so that it will adhere better, and then put it onto the burned areas of the body. Now, which of these areas is going to hurt worse, the recipient or the donor site? I can tell you it's going to be the donor site, because that's like a floor burn or a carpet burn. So the donor site is going to be quite painful. So let's talk about nursing care for both donor and recipient sites. On the donor site, will be covered usually for a day or two, 24 to 48 hours. Now, a bed cradle might be used. A bed cradle is a device that actually goes, usually tucks into the sides of the mattress, goes up over. It's a curved, usually it's metal, a curved metal rod, and it keeps the bed linens from touching the extremities. So if the patient had burns of the legs, they might have this bed cradle that would keep the sheets from touching the legs. So that's what a bed cradle refers to. Now, the outer dressing will be removed in a day or two or three, depending upon the physician and the patient. And eventually that fine mesh gauze that is the inner dressing will fall off. This site is painful, so analgesics might be needed for the patient. The recipient site isn't going to hurt, so that's not an issue for it. Depending upon the site, it's usually kept elevated. We certainly don't want edema and pooling in the area. A bed cradle, again, may be indicated to keep the bed linens off from the site. Warm compresses are often ordered, and certainly you would check the circulation. Now, please don't just pick up a corner of that and look at it and say, is it taking? Obviously not. You want the graft to stay in contact with the burned area. So that's a little bit about